Preterm labor. Preterm labor is the presence of contraction of sufficient strength and frequency to effect progress, effacement, and dilatation of the cervix. An incidence about 7 to 10%. There is subclassification of preterm labor according to the late preterm 34 to 36 week, moderate preterm between 32 to 34 week, and very preterm less than 32 week. The preterm labor, most mortality and morbidity is experienced by baby born before 32 weeks. The prediction of preterm labor. Assessment of risk factor, vaginal examination to assessment the cervical state, ultrasound to visualize the cervical length and dilatation, and detection of fetal fibronectin in cervicovaginal secretion. Risk factor, the exact cause of preterm labor is unknown, but there is multiple risk factors that affected on a preterm incidence of a preterm labor. A risk factor, young age less than 16, low socio-economic class, reduced body mass index less than 19, cigarette smoking, and previous preterm labor is most important risk factor, the incidence about between 20 to 40%. Other causative factor, as mentioned, infection is most important cause of preterm labor, but there is other cause risk factor. Most important is over-distended uterus, such as multiple pregnancy, polyhydramnios, other cervical incompetence, uterine abnormality, and obstetrical complications that causing iatrogenic prematurity, such as preeclampsia, placenta previa. Vaginal examination by digital examination is a traditional method used to detect the cervical maturation, but quantifying these changes is often difficult. Vaginal ultrasound to measure the length of cervical length, to prediction of a preterm labor. Fibronectin is glycoprotein presence in the cervicovaginal discharge secretion between 23 to 34 weeks. Any disruption between 23 to 34 weeks is rarely present. So if it is present, it gives a prediction for preterm labor. This test has high negative predictive value. The risk of a preterm labor is less than 1% with negative results. Prevention of preterm labor. First, identify a risk factor of a preterm labor, screening and treatment of bacterial vaginosis, screening and treatment of urinary tract infection, and testing for gram-positive streptococci infection in high-risk patients, and stop the smoking. Cervical cerclage. After the document of short of cervix, which means less than 3 cm, cervical cerclage may improve the outcome, especially patient with history of previous recurrent and very early delivery. Diagnosis criteria to document preterm labor. Regular uterine contraction occur 4 times per 20 minutes with cervical dilatation and effacement. Dilatation more than 1 cm and effacement about 80%. Vaginal ultrasound and fibronectin, as we mentioned, cervical length with presence of fibronectin and cervicovaginal secretion. The treatment The aim of a treatment, inhibition of labor. 2. Advantage from giving of steroid. Inhibition of labor by bed rest, but this is controversial, hydration and sedation and tocolytic. Until effective strategies are found, should be aimed to preventing newborn complication by giving corticosteroid, antibiotic against gram-positive strepto, avoiding traumatic delivery and delivery in center with experienced resuscitation and neonatal intensive. A tocolytic, which is better for stop uterine contraction. Most authors don't recommend the use of tocolytic at or after 34 weeks. A choice of tocolytic drug, magnesium sulfate and prostaglandin antagonist and calcium channels with oxytocin antagonist. The most important drug used is calcium channels blockers, which is nifedipine, and oxytocin antagonist, which is atosiban. Atosiban, as mentioned, and nifedipine, it is preferred because of its side effect. Beta sympathomimetic drug like ratodrine and ventolin, because it has many complications such as maternal pulmonary edema, myocardial ischemia, and fetal complication, arrhythmia, hydrops, pulmonary edema, and even cardiac failure. So it is best avoided this drug. Magnesium sulfate, it is a smooth muscle relaxant and can be used in a treatment of preterm, but there is little evidence suggests an increase in efficacy or improve outcome. The nitric oxide, which is a nitroglycerin, which is used as patch, and there is insufficient evidence to support using routinely. The endomethacin, which is best used for only 72 hours and gestational age less than 32 weeks because of its complication, which causing premature closure of ductus arteriosus, renal and cerebral vasoconstriction, and necrotizing enterocolitis. The steroid, antenatal given steroid for maturity of lung of the baby and reduction rate of RDS and neonatal death. Steroid, there is two ways for giving, because there is hydrocortisone and betamethasone. Betamethasone, 12 milligram doses of betamethasone given IM 24 hours apart, or 4 of 6 milligram doses of dexamethasone given IM 12 hours apart. There is no proof different with efficacy of any regime. In antibiotic, there is no evidence of clear benefit for prophylactic antibiotic for preterm with intact membrane on a neonatal outcome. Maybe advantage of antibiotic in patient with a premature rupture of membrane. Because of group B streptococci is the most important bacteria, so we give erythromycin antibiotic to prevent sepsis and meningitis late for a neonatal. The other subject is a pre-labor rupture of membrane. Rupture of membrane with leaking of amniotic fluid in absence of the uterine activity. Preterm pre-labor rupture of membrane occur when rupture of membrane occur before 37 weeks of gestation. Etiology: infection is the major causes, which is bacterial vaginosis, previous pre-labor premature rupture membrane and preterm labor, antepartum cervical incompetence, and overdistended of uterus. The diagnosis depends on the history, gush of fluid or profuse watery vaginal discharge, examination by sterile speculum introduced through the vagina, and we see the amniotic fluid come from the cervix, and if not, slightly pressure on the fundus to see the coming of amniotic fluid. Nitrazine test: because of the amniotic fluid is alkaline, pH between 7 to 7.5, so the nitrazine paper changed the color to blue. Other test, which is Fernic test. And Fernic test is because of the presence of electrolyte, which is a sodium chloride, causing crystallization when dry the amniotic fluid on a glass slide, causing crystallization which appear under microscopic examination. Other ultrasound, and it is not a primary diagnostic test in a preterm, but only used to assessment the amniotic fluid volume and index. Vaginal swab, which is used to detect presence of high concentration of fetal fibronectin and beta HCG in amniotic fluid if a presence in the vagina. Preterm labor: there is complication of premature rupture of membrane, one of them preterm labor, and the second and most important, it is chorioamnitis, which is infection occur in the first 48 hours of rupture of membrane. The clinical diagnosis of chorio: first, maternal pyrexia more than 38, and at least 2 of either maternal tachycardia more than 100 beat, fetal tachycardia more than 160, uterine tenderness, offensive vaginal discharge, and increased C-reactive protein. The treatment of chorio is antibiotic with delivery. Other of complication of pre-labor rupture of membrane: cord prolapse, placental abruption due to an increased incidence of premature rupture of membrane because of reduction in intrauterine surface area leading to the placental detachment. Fetal deformity, pulmonary hypoplasia, haline membrane disease, increased perinatal mortality, and fetal distress due to oligohydramnios lead to cord compression and late deceleration of fetal heart. General measure by do and cervical swab for gonorrhea and chlamydia, sample for group B strepto, urine sample for culture, and according to the gestational age. If a premature rupture of membrane occurs more than 34-week gestation, the risk of infection greater than the benefit of maturity of the lung, so induction of labor. If a premature rupture of membrane occurs before 34, so expectant management unless the labor starts spontaneous or there is sign and symptom of chorioamnitis. Expectant management include monitoring of vital signs, pulse rate, temperature, blood pressure taken every 4 hours. Hypotension indicate of sign of septicemia, and blood test white blood cell C-reactive protein not need to done 3 times per week. Fetal monitoring with CTG, elevation of fetal heart rate of 10 beats per minute above the previous heart rate may indicate chorioamnitis, maternal steroid to accelerate lung maturity, but there is controversy about this. Antibiotic by giving erythromycin 250 mg 4 times daily for 10 days can reduce perinatal morbidity and mortality. Delivery is indicated when there is sign and symptom of infection and there is fetal compromise. Amniocentesis sometimes needed to confirm diagnosis of infection, so sample of amniotic fluid taken and sent for gram-positive and culture and sensitivity. Thanks.